1, 2,
and female.
Oh shit, almost got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the phone.
It's
300 please.
I'll keep your card again.
Pulse check. No pulse.
no more pulse.
Yeah. Where the echo people get? And her blood pressure is also dropping.
45 minutes of CPR and no return of circulation. Okay.
Hey guys, this right here is going to be the pharmacology section or critical care pharmacology section. And this one is specifically going to be for your RSI drugs. Now, RSI is rapid sequence induction, or that's basically going to be your intubation pathway or your intubation algorithm, however you want to look at it. So you have a few popular and common sedatives, which are going to be Etomidate, ketamine, propofol, and Versed, or midazolam, right, for generic name. And then your paralytics your two big ones are going to be rock and sux. All right. So succinylcholine and rocuronium are competing for like top spots. But rock has a longer duration than sux does. So if you got someone that's going to be a difficult intubation or a difficult tube, you're going to be probably using rock because you get that 30 to 60 minute window of paralytic properties. But you also have vecuronium. That right there was the med that Redonda Vaught accidentally gave her patient before she went for MRI or CT. And she gave way too much of it and robbed the lady's drive to breathe quite physically. So that's Vec. But the two most common drugs that I have seen used for intubation is definitely going to be Etomidate and rock. Now, guys, because we all operate on a perverted mind, just always, always, always remember you're going to date someone before you suck them, or you're going to date someone before you rock their world. Okay? Easy way to remember it. So you're always going to put someone under. You're always going to sedate them before you paralyze them. Okay? So date before you suck, date before you rock. Right? So Etomidate, rock, Etomidate sucks, or ketamine, rock, ketamine sucks, whatever you guys want to use. Right? But that's kind of the way to do it. Okay? So all of the drugs that are going to be annotated with RSI are going to be your RSI drugs. Now, the exceptions are probably going to be midazolam and ketamine. Midazolam because it acts as also an anxiolytic, but it's not typically used for that, but it can be. And then ketamine is another chic drug that's coming back into popularity. After it was taken out of popularity, it's coming back with a vengeance. So just a quick thing on ketamine is low dose. You're going to be getting into that psychotherapeutic range where they use it for like CBT and stuff like that. And then you have the mid-range dose, which is going to be for pain control, like up to 50, I think it's 50 mics or maybe 50 megs. One of the two, it's 50 something. And then you have your mod sed, which is going to be anything over like 50 and above, right? From what I understand, and again, this is me, I'm going to learn it just like you guys. But from what I understand, ketamine does not really have the properties of slowing down respirations, but that's just what I've been told. And we'll find out together when we listen to the episode over ketamine. Okay. So again, this is going to be your RSI drugs. They're going to be annotated as such with RSI. And it's important that you know your RSI drugs because you as the nurse will be pushing Etomidate. You as the nurse will be pushing rock. You as the nurse will be pushing Versed for these critically ill patients that you need to take their airway. Okay. So just kind of keep that in the back of your mind why you're giving these meds and listening to this, because you will be needing to know this as you're giving this med. Okay? All right, guys, enjoy the episodes.
So, picture this. You're standing in the trauma bay.
Right. High stakes.
Exactly. EMS just crashed through the double doors with a patient from a really bad high-speed motorcycle accident.
Hold on. Yeah.
They've got severe head trauma. So naturally, their brain is swelling, and that intracranial pressure is just spiking dangerously high.
Which is a nightmare scenario right there.
It is.
Yeah.
But to make matters worse, they're also hypotensive. They're bleeding internally somewhere, blood pressure is plummeting, they're combative, and their airway is completely compromised.
So you need to act fast.
Right. And as the elite critical care nurse or, the pharmacist in the room, you're holding a syringe. You have to make a choice for rapid sequence intubation or RSI.
And it's not an easy choice.
No, because if you push propofol, which is usually the standard go-to, the vasodilation is going to crash their blood pressure even further. You're basically going to cut off all perfusion to their already damaged brain.
Which you absolutely cannot afford to do.
Exactly.
Yeah.
You need a drug that threads this nearly impossible needle, something that'll put them under in like 30 seconds, lower the pressure in their skull, and somehow not even touch their systemic blood pressure.
Which brings us to today's drug, Etomidate, or you might know it by its brand name, Amidate.
Right, the absolute MVP for this specific scenario.
It really is. When you're looking at that hemodynamically unstable trauma patient, this is the drug of choice. It has this incredibly unique pharmacological profile.
So today, for this deep dive, we're putting on our critical care pharmacist and nursing pharmacology instructor hats. We're getting granular.
Yes, we are aggressively applying the 80-20 Pareto principle to Etomidate.
Which means we're cutting out all the fluff. We want to drill down into the exact mechanisms, the why and the how, so you get the absolute essential clinical understanding, stuff you actually need at the bedside and for your exams.
Right. Because to really master Etomidate, you have to understand its fundamental paradox.
The Jekyll and Hyde thing.
Exactly. On one hand, it acts as this hemodynamically perfect savior for the brain and the cardiovascular system. But at the exact same time, it acts as a targeted poison for the adrenal glands.
It's wild. Well, let's start with the savior side, the expected pharmacological action. How does Etomidate actually put this highly agitated, combative trauma patient to sleep in literally seconds?
So it all comes down to facilitating GABAminergic neurotransmission.
Okay, GABA.
Yeah, GABA. Gamma-aminobutyric acid. It's the primary inhibitory neurotransmitter in your central nervous system.
The brakes of the brain, basically.
That's a great way to put it. When GABA binds to its receptors, it basically tells the brain to calm down, to stop firing so many signals.
Yeah.
And Etomidate significantly increases the number of available GABA receptors.
I actually want to pause on that mechanism for a second, because it doesn't just flood the brain with more GABA, right?
No, it's more clever than that.
Yeah, because the source material notes it actually displaces endogenous inhibitors. So if we think about the GABA receptor like a highly contested seat at a club or a game of molecular musical chairs.
I like the club analogy.
Right. So GABA is the bouncer trying to calm things down. Etomidate isn't just handing the bouncer a megaphone or just adding more chairs. It's actively pulling the other people trying to distract the bouncer out of the line, opening up more VIP lines for sleep.
That is a highly accurate way to visualize it. By removing those endogenous inhibitors, the pathway is completely cleared for GABA to do its job with maximal efficiency.
No competition.
Exactly. And the clinical result of this unobstructed GABA activity is what we call neocortical sleep.
Neocortical sleep.
Yeah, based on animal studies, this profound sleep state is driven at least partially by the depression of the brainstem reticular formation.
Okay, then the reticular formation is essentially the brain's control room for wakefulness and consciousness.
Right?
Spot on. So you depress that control room, GABA takes over the newly available receptors, and boom, the patient goes under.
They're out. But getting back to our trauma patient, putting them to sleep is really only half the battle.
Right, because we still have that swelling brain to deal with.
Yeah, exactly. Which brings us to the physiologic effect, which is honestly the primary reason Etomidate gets pulled from the pyxis in these high-stakes scenarios.
Okay, walk us through it. What happens when it hits the vein?
When that medication hits the bloodstream, it causes a transient 20% to 30% decrease in cerebral blood flow.
Wow, that's a lot.
It is. And assuming there are no space-occupying lesions, like, a massive localized tumor, this reduction in blood flow is uniform across the whole brain.
So let's connect that to the intracranial pressure of the ICP for everyone evaluating this at the bedside.
Please do.
The skull is a rigid vault. It's bone. It cannot expand. Inside that vault, you got three things: brain tissue, cerebrospinal fluid, and blood. If the brain tissue is swelling from trauma, the pressure goes up. But if etomidate drops the volume of blood flowing in that vault by 20 to 30%, you are freeing up a ton of crucial space.
Which results in a moderate but highly predictable decrease in intracranial pressure. You are literally actively protecting the brain from crushing itself.
That's incredible.
It is. But here's the true magic trick. The reason you're using this instead of, say, another induction agent is what's happening to the rest of the body while that brain pressure drops.
The hemodynamics.
Yes. The systemic blood pressure remains remarkably stable. It achieves the cerebral effect with minimal impact on the cardiovascular system.
Wait, I actually need to push back on that slightly.
Okay, cool.
Because almost every sedative we use in the ICU causes some level of vasodilation or myocardial depression. I mean, propofol definitely does. How is etomidate dropping blood flow to the brain without tanking the mean arterial pressure everywhere else?
It's a great question. And a major part of the answer lies in what etomidate does not do.
Which is?
It triggers zero histamine release.
Zero.
None. Think about when you administer drugs like morphine or even certain muscle relaxants. They can cause the mast cells to dump histamine into the bloodstream.
And histamine is a huge vasodilator.
Exactly. It opens up the blood vessels, which causes systemic blood pressure to plummet. And, it can also trigger bronchospasm in the lungs.
So by completely bypassing that histamine response, etomidate avoids that sudden catastrophic drop in blood pressure.
Right. It's a massive clinical advantage for an unstable trauma patient.
Okay, so let's talk about evaluating the effectiveness at the bedside. Let's say you push the standard adult dose, which is usually 0.3 milligrams per kilogram.
Yeah, 0.3 milligrams per kilogram intravenously.
So how fast is the onset once you push it?
Oh, you'll see the minimal hypnotic plasma concentration achieved almost instantaneously. The onset of action is lightning fast. We're talking between 30 and 60 seconds.
Right.
Yeah, half a minute to 1 minute, and your patient is totally under.
And how long does it last? What's the duration?
It's very short-lived. At that standard dose, the duration of hypnosis is only about 3 to 5 minutes.
Just 3 to 5 minutes?
Yeah, I mean, it is dose dependent, so if you push a little more, they stay under a little longer. But generally, it's designed to be a quick in and out.
Which perfectly aligns with its therapeutic uses,
Yeah.
right? We're talking about general anesthesia induction and sedation during RSI.
Exactly.
But there is a massive clinical caveat here, especially regarding procedural sedation. Etomidate is strictly a sedative-hypnotic. It has absolutely zero analgesic properties.
Zero. This is a critical nursing pearl that honestly cannot be overstated.
Yeah, break that down for us.
Etomidate will put the patient to sleep, sure, and it will induce amnesia for the event, but it does absolutely nothing to block the physiological pain pathways.
So if you're using this to sedate someone while a physician, say, reduces a complex shattered femur.
Right. The patient's eyes will be closed and they won't remember it later, but their central nervous system is still fully experiencing the excruciating trauma of that bone being manipulated.
That is so important. You cannot let the closed eyes fool you into thinking the patient doesn't need pain management.
No, absolutely not.
You still have to push an analgesic like fentanyl alongside it. The brain might be in neocortical sleep, but the body's stress response to pain is still firing on all cylinders.
Which seamlessly transitions us to the darker side of this drug's profile.
Behind to the Jekyll.
Exactly. You just mentioned the body's stress response. Etomidate is the MVP for rapid intubation because it's fast, hemodynamically stable, and lowers ICP. But if it's so perfect...
Why isn't it running on a continuous IV drip in every ICU room across the country? Right?
Exactly. Why aren't we using it for long-term sedation?
Because of its fatal flaw. The most dangerous adverse effect of this medication. It aggressively attacks the adrenal glands.
It really does.
Let's walk through this reasoning pattern because this is the single most important thing you need to know about etomidate. Let's go from mechanism to physiologic effect to adverse effect.
Okay, so structurally, the drug inhibits steroidogenesis. Within the adrenal cortex, there is a specific enzyme called 11-beta-hydroxylase.
11-beta-hydroxylase. Got it.
This enzyme is a critical piece of the assembly line that manufactures your body's stress hormones, specifically cortisol and aldosterone. And etomidate chemically blocks 11-beta-hydroxylase.
Wait, I know the body usually has backup systems for critical functions like this. Does blocking this single enzyme really shut down the entire stress hormone production line?
Completely. It causes a total bottleneck. Without 11-beta hydroxylase, the precursor molecules literally cannot be converted into active cortisol and aldosterone.
So the assembly line just grinds to a halt.
An absolute halt, and it does this profoundly even after just a single induction dose. Your plasma cortisol and aldosterone levels plummet.
And what happens if the brain senses this drop? Doesn't the pituitary gland start screaming at the adrenal glands to produce more? It releases ACTH, right? Adrenocorticotropic hormone.
It does, but the adrenals cannot respond. They are functionally paralyzed. Even with super high levels of ACTH stimulation, the blocked enzyme prevents any cortisol from being synthesized.
That's terrifying for a critical care patient.
It is. When someone is critically ill, their body requires a massive cortisol surge just to maintain vascular tone, regulate metabolism, and manage the physiological stress of the trauma or the infection. Etomidate completely strips them of that defense mechanism.
Which leads us directly to the absolute highest priority nursing intervention. Because of this profound adrenal suppression, you must never administer Etomidate by prolonged, continuous infusion for ICU sedation.
Never.
It is strictly a one-and-done push for induction.
And to really understand the gravity of that rule, we can look at the early days of its use.
Oh, right, before they knew about the adrenal issue.
Exactly. Before this adrenal mechanism was fully understood, clinicians saw how beautifully stable it kept blood pressure. So what did they do? They started running it as a continuous sedation drip in intensive care units.
And what happened?
The mortality rate spiked dramatically. Patients were dying of cardiovascular collapse and shock because their bodies were entirely unable to mount a physiological stress response to their underlying illnesses.
Wow, so you basically induce a prolonged iatrogenic adrenal crisis if you leave it running.
Exactly, so one and done.
One and done. Okay, so moving away from the most dangerous side effect, let's look at the most common. Because this is a massive test point for exams like the NCLEX and ATI, and honestly, a critical piece of client and family education at the bedside.
You're talking about the myoclonia.
Yes, the involuntary muscle jerking. The source material notes this occurs in a staggering 74% of patients receiving the drug.
74%.
That is not a rare side effect. That is basically an expected feature of the administration.
It is.
And as the nurse or pharmacist in the room, if you are doing a rapid sequence intubation in the ER, you often have the patient's terrified family members standing right there in the corner of the room.
Right. So imagine you push the syringe over 30 to 60 seconds, the drug takes full effect, and suddenly the patient's limbs start jerking and twitching rapidly.
To an untrained eye, that looks exactly like a generalized seizure.
It does. And if you haven't prepped the family, they're going to panic. They'll scream that you just gave their loved one a seizure. It changes the entire dynamic of the trauma room from a controlled, elite clinical process into complete chaos.
Which is why anticipation and education are your primary tools here. Before you even uncap that syringe, you turn to the family and explain exactly what's going to happen.
Communication is key.
You say, when I give this medication, you are likely going to see their arms or legs twitch and jerk. This is an expected reaction to the drug. It is not a seizure, and it simply means the medication is working to put them to sleep.
Brilliant. You completely reframe a terrifying visual into a reassuring sign of effectiveness.
Exactly. Now, beyond the adrenal suppression and the myoclonia, what other severe rapid onset complications are we monitoring for the second this hits the bloodstream?
Well, you have to monitor for apnea, which is a cessation of breathing.
Though, practically speaking, if you're using this for rapid sequence intubation, you're intentionally taking over their airway anyway.
True. But you also need to watch for laryngospasm, sudden unexplained bradycardia, the exacerbation of underlying arrhythmias, and potentially rapid anaphylactoid reactions.
Which just highlights why this medication is exclusively administered by individuals specifically trained in the use of general anesthetics and airway management.
Absolutely. Don't mess around with it.
Let's dive into the mechanics of that administration and some specific precautions. We established the standard dose is 0.2 to 0.6 milligrams per kilogram, pushed intravenously.
Right. And you must visually inspect the vial for particulate matter before drawing it up.
Basic safety.
Yeah. And while there are no strict, mathematically calculated max doses or hard contraindications for organ impairment, caution is heavily advised for patients with hepatic or renal issues.
Okay, so if I have a patient with severe cirrhosis or maybe a history of bleeding esophageal varices indicating portal hypertension, why am I considering a lower dose?
Because of how the drug is metabolized and cleared. Etomidate undergoes rapid ester hydrolysis in the liver.
Ester hydrolysis.
Yes. This process breaks the drug down into an inactive acid metabolite, which accounts for about 80% of what is eventually excreted in the urine. So if the liver is failing, that ester hydrolysis slows down.
And if the kidneys are failing, the excretion slows down.
Exactly. In either case, the drug is going to circulate longer than its normal 75-minute half-life.
I actually want to highlight something incredible about that liver metabolism. The source notes that etomidate affects 0 cytochrome P450 isoenzymes. None.
Which is amazing. For managing a critical care patient, that is an absolute polypharmacy superpower.
Totally, because the CYP450 system in the liver is the primary metabolic pathway for a massive percentage of the drugs we use.
It is.
If you think of the CYP450 system as a busy, multi-lane highway in the liver, most medications have to sit in that traffic to get broken down. If you put too many drugs on the highway, they collide, they block each other, and they alter each other's metabolism, which leads to toxicity.
But etomidate doesn't use the highway.
Right. It takes a private toll road via ester hydrolysis, entirely bypassing the traffic jam.
Which removes a massive layer of complexity when you're dealing with a trauma patient who might be receiving a dozen different continuous infusions.
So there's still a few drug interactions to be aware of, right?
Yeah, definitely. If you are administering intravenous fentanyl or other neuroactive agents alongside it, which, as we discussed, you often do for pain control, those agents can alter the dosage requirements of etomidate.
Meaning you might need less.
Exactly. You may find you need a smaller induction dose to achieve the same neocortical sleep.
But the interaction doesn't necessarily flow both ways, specifically regarding paralytics. The source explicitly points out that etomidate hypnosis does not significantly alter the usual dosage requirements of the neuromuscular blocking agents used right after it.
That is a crucial workflow detail for RSI. You push the etomidate to sedate, and then immediately push a paralytic like succinylcholine or rocuronium to paralyze the vocal cords for the breathing tube.
And you don't need to do any bedside calculus to adjust your paralytic dose just because you used etomidate first?
Nope. They operate completely independently in that sequence.
Nice. Let's touch quickly on another common bedside question. Pregnancy and lactation. If a mother requires surgery or intubation, when is it safe to resume breastfeeding?
The clinical data here is highly reassuring, actually, and it's mostly due to that rapid ester hydrolysis we just discussed. In a study of women undergoing cesarean sections who received the standard 0.3 milligram per kilogram dose, maternal serum concentrations were completely undetectable by the 2-hour mark.
Wow, 2 hours. And what about the breast milk itself?
In the colostrum, the drug was barely traceable at 30 minutes and completely undetected in any sample by 4 hours post-dose.
That's great.
Yeah, the established clinical guidance is that a healthy term infant can safely nurse as soon after surgery as the mother is awake, alert, and able to hold the child.
That fast half-life really is a clinical blessing. Okay, so we have thoroughly mapped out the savior and the poison aspects of this drug. But there is a plot twist in the pharmacology.
Oh, this is the best part.
It is. This is where clinical critical thinking gets truly fascinating. We spent a significant amount of time detailing etonidate's absolute worst flaw, which is its ability to completely shut down cortisol production by blocking 11-beta-hydroxylase.
Right, the very mechanism that caused mortality spikes when they used it as an ICU sedative drip.
Exactly. But what if a patient rolls into the intensive care unit and their primary life-threatening problem is that their own body is producing a lethal, uncontrolled amount of cortisol?
Ah. You are describing severe hypercortisolism, which is most commonly seen in critical cases of Cushing's syndrome. These patients are in a full-blown endocrine crisis. Their blood pressure is sky high, their metabolism is severely deranged, and they are often way too unstable to take oral medications.
So in this highly specific scenario, clinicians utilize a brilliant off-label strategy. They take the drug's most dangerous adverse effect, and they deploy it as a targeted weapon. They use a continuous IV infusion of etomidate.
They literally flip the poison into a cure. Now, they aren't using the 0.3 milligram per kilogram induction dose. They use a significantly lower continuous rate, usually between 0.04 to 0.1 milligrams per kilogram per hour.
Because at that low rate, you aren't putting the patient into a neocortical sleep, they actually remain awake.
Right, but you're still introducing enough of the drug to utilize that 11-beta-hydroxylase blockade.
It's genius.
The clinical studies show that this low-dose infusion provides approximately 100% serum cortisol control. It forcefully wrestles the hypercortisolism to the ground by shutting down the adrenal assembly line right on command.
But, and this is big, but if you're doing this, especially if the patient's condition requires you to titrate up to higher doses, like 0.5 or 1 milligram per kilogram per hour, there is a massive mandatory pharmacy and nursing intervention that must accompany the drip.
Yes, you have to administer hydrocortisone as an add-back treatment.
Walk us through the logic of that add-back treatment.
Yeah.
Because if the goal is to stop cortisol, why are we giving them synthetic cortisol?
Because Etomidate is too effective. It doesn't just lower the cortisol to a normal level, it obliterates production entirely.
Wow.
So if you just run the drip, you will push the patient from a hypercortisolism crisis straight into an adrenal failure crisis.
You're just as bad.
Exactly. By chemically removing their endogenous unpredictable cortisol with the Etomidate and then intentionally pumping in a highly controlled synthetic dose of hydrocortisone, you're essentially taking manual, overriding control of their entire physiological stress response.
It is just a phenomenal example of why memorizing a list of side effects is never enough. I mean, if you only memorize that Etomidate is bad for the adrenal glands, you completely miss the opportunity to understand how that specific mechanism can be engineered to save a life in an endocrine unit.
Understanding the why unlocks the true utility of the pharmacology.
It really does. All right, let's bring this all together. If you're prepping for a critical shift or you're sitting down to your pharmacology boards, we're going to distill this down to the 20% of information that will give you 80% of your clinical results.
Let's do it.
Let's start with a high-level heuristic to organize your mental framework when you pull this file.
We use the 3 E's of Etomidate.
The first E, excellent for hemodynamics and intracranial pressure. It drops the pressure in the skull without crashing the systemic blood pressure, thanks to zero histamine release.
The second E, extremely bad for the adrenal glands. It profoundly suppresses steroidogenesis by blocking 11-beta-hydroxylase.
And the third E, expect myoclonia. 74% of your patients will experience rapid muscle jerking, requiring proactive family education.
Excellent hemodynamics, extremely bad adrenals, expect myoclonia.
Love it. Now let's run through the absolute top 5 critical high-yield facts to cement this, if they remember nothing else from this deep dive.
Fact 1. Etomidate is a short-acting, rapid-onset intravenous sedative-hypnotic used primarily for anesthesia induction and rapid sequence intubation, boasting a 30 to 60-second onset.
Fact 2. It is the absolute drug of choice for hemodynamically unstable patients, particularly those with traumatic brain injuries, because it reduces intracranial pressure while maintaining critical blood pressure perfusion.
Fact 3. The most dangerous adverse effect is adrenal suppression, caused by the structural inhibition of the 11-beta-hydroxylase enzyme, halting cortisol and aldosterone production.
Fact 4. Because of that severe adrenal suppression, Etomidate must never be used as a continuous ICU sedation drip, as it will induce an iatrogenic adrenal crisis. The only exception is the highly specific off-label treatment of severe Cushing syndrome.
And fact 5. Anticipate myoclonia in the vast majority of your patients upon administration, and verbally educate the room beforehand so it is not mistaken for a neurological seizure.
That is the essential clinically actionable profile of Etomidate. You now know not just what to push, but exactly what is happening at the receptor and enzyme levels the second it enters the vein.
And you know, there is a profound philosophical takeaway hidden in the pharmacology of this drug.
Yeah.
Etomidate represents an incredible clinical paradox. Its greatest safety risk, the ability to paralyze the human body's natural stress response, is the exact same mechanism that makes it a targeted precision cure for a rare endocrine disease.
It really forces you to look at the rest of the pieces differently.
Yeah.
Like, how many other catastrophic, dangerous side effects sitting in our medication cabinets are actually just highly specific cures, quietly waiting for us to find the right disease?
Exactly.
Pharmacology is rarely just black and white. It's entirely dependent on the specific pathophysiology of the patient in front of you. So keep exploring those mechanisms. Keep asking why.